Okay, well, good day, everyone. Good morning to those of you on the East Coast, or good afternoon on the East Coast, and good morning elsewhere in the U.S., as well as elsewhere if you're calling in. I want to welcome you, everybody, to today's SCC-sponsored webinar by Cleerly, which we entitled An End-to-End AI Solution for Precision Heart Care. I am Jay Earls. I'm the Chief Medical Officer here at Cleerly. And I have a wonderful panel today that I will be introducing shortly, and moderator for today's program. We do have a very profound purpose here at Cleerly as a company, is that we want to create a world without heart attacks. And we know this is obviously, we're biting off a lot here, but it is our desire to establish a new standard of precision heart care. Specifically through quantification, characterization, and then tracking of an individual's actual heart disease, rather than following indirect markers of disease, which we have been doing for many years. I think we all know that CT itself as a modality has come a long way in the past decade or two, to the point now for both stable and acute chest pain and low to intermediate risk patients. It is now the preferred modality, both here in the U.S. as well as overseas in the U.K. and Europe. But this is primarily based upon CT's ability to detect stenosis. Beyond stenosis, we actually, in fact, feel that the atherosclerosis, which CT also has a tremendous ability to evaluate and quantify, is probably the key to really improving our patients' health in the future. We know that on CT, atherosclerosis has a very varied appearance. It can look anywhere from very low density lesions to more intermediate density and then to high density lesions. And we also know that the risk to the patient for a future event is directly or indirectly proportional to the density seen on CT. So we know that the dark plaques are the ones that cause acute coronary syndromes. The bright plaques or calcified plaques are much more stable plaques and likely cause little, if any, significant downstream events. But fortunately, we also have learned that these plaques can transform over time through lifestyle modifications as well as medical therapy. And we believe that directing that transformation will hopefully in the future prevent heart attacks by reducing an individual's risk. So we have 6 different machine learned algorithms that take the CT acquired at your or your local site. We will analyze them to determine the amount of plaque which is present, the type of plaque that's present, the number and degree of stenoses, et cetera. So we really do give a very comprehensive analysis of all of the epicardial coronary arteries that are greater than 1.5 millimeters in diameter. That can then be viewed on our primary software, as you see on the left, which is what we call labs. We also have a second reporting software called Cleerly Coronary. We also produce a PDF comprehensive report that can be ingested into the electronic medical record, our PACS. And we also actually offer a 4th report, or analysis, which can be shared with the patient so they can understand their own disease and disease process. Our outputs have been validated on numerous multi-center clinical trials. We've compared our outputs with expert level 3 clinical readers, invasive angiography, invasive fractional flow reserve, intravascular ultrasound, and also near-field infrared spectroscopy. Our outputs, as you can see here, give you a summary of the patient's report on a high level, how much atherosclerosis they have, what degree of stenosis they may have, et cetera. We then give a detailed description of the amount of atherosclerosis and include that into the relatively new staging system, which is based upon the stage or quantity of plaque which is present. We give a sort of a detailed analysis using CAD-RADS type categories of the per segment stenoses which may be present. And then finally in our report, we'll give at least one image of each vessel highlighting the patient's plaque and stenosis, which can then be viewed readily. As I said previously, we also share some of that information in a detailed report that can be shared with the patient. It's written in FDA-compliant 5th grade English, so a patient can really understand exactly what coronary disease is, what coronary plaques are, how do coronary plaques respond to therapy, and then we share with them their own images. We have found, or certainly through many of our providers have given us feedback, this can be enormously helpful in patient compliance, as well as engaging them in an active discussion about their disease process. Our outputs have been used recently by the American College of Cardiology Innovation and Prevention Working Group. They recently published an expert consensus guideline that uses a combination of plaque stage, which we would output, with the patient's risk factor, putting both together to precisely determine a patient's medical therapy. So, for instance, if a patient is diabetic, previously they may just have had one type of medical therapy that was recommended, but in fact now there will be different levels of medical therapy that are appropriate depending upon the amount of atherosclerosis that's present. They also actually recommended a rescan interval. Rescan interval is to ensure that that medical therapy is working. So someone with stage 2 disease, as you can see here, would be rescanned in 2 years to see if, in fact, the plaque is progressing or stabilizing or maybe even reducing in volume. In that case, if it is, then you know the medical therapy is working. If it's progressing still, then it's an opportunity to intensify or change the medical therapy that's been prescribed. And this ability to disease track is something that we have built into our software and is approved by the FDA. I think clinical readers are very good at detecting stenoses, but it's actually relatively hard for us as clinical readers. There's a large amount of variability when we look at one study, compare it to another, and try to determine if the plaque volume is increasing, stabilizing, or decreasing, or even to say if that plaque volume is transitioning into a different phenotype. So here you can see in this on this study, we can quantitatively look at these two studies performed 3 years apart. We have found the total plaque volume has not changed over time, but you can actually look at individual plaque composition, and we can here quantitatively say, well, the yellow plaque, which is for us is non-calcified plaque, is actually decreasing. The low-density plaque, not featured on this image, is also significantly decreasing, and the calcified plaque is increasing. So this really is a definition of successful therapy. We've stopped progression of disease, and now we're transforming disease from a more risky to a less risky phenotype over time. So putting these all together, this is really what we consider the Cleerly digital care pathway. One is to identify the disease that's present in a unique way with whole heart phenotyping of atherosclerosis. We can then educate the prescriber, the physician taking care of the patient, transforming this phenotype into actionable clinical insights. We can also empower the patients themselves with improved health literacy, which can strongly encourage compliance on their behalf. We now have the ACC Innovation and Prevention Task Force treat disease algorithms that can recommend therapy based upon the phenotype that we described. And then, of course, we can track this over time to make sure that patient's disease is successfully stabilized and hopefully transformed into a less risky phenotype. And ultimately, we want to do all of this in order to prevent future events. We have a number of large-scale multi-center clinical trials that we are standing up, evaluating this pathway, and hope to have some good evidence in the near future to demonstrate the success of this pathway. So this is just an introduction. We have a couple of very exciting speakers and one also very learned moderator today. I want to introduce Dr. Ricardo Cury. Many of you know him as a past president of the MSCCT. He is currently professor and chair of radiology at Florida International University, as well as Baptist Health in South Florida. So I will turn it over to you, Ricardo. Thank you.
Thank you very much, Jay. It was a great overview of the capabilities for AI, full plaque quantification, and how may enhance our ability to identify, track, and monitor disease. So thank you so much for this introduction and high-level overview. With that, we have two great speakers. I'm Ricardo Cury, and we will have two talks, and then we'll open for Q&A. And if you have questions, you can put in the chat. So the first speaker is Dr. Andrew Choi, and Dr. Choi is the co-director of multimodality cardiac imaging at the George Washington University School of Medicine in Washington, an associate professor of medicine and radiology, and has made numerous contributions to the field of cardiac CT. Thank you, Dr. Choi.
Thanks, Ricardo, and thank you for the kind introduction, and also thank you to Jay, Cleerly and SCCT for being part of this webinar. And really, I think we're joined by a really expert audience in cardiac CT, cardiovascular medicine, and radiology. And I hope we can provide some clinical context and really go through the science of what the Cleerly technology has to offer and use that evidence base to be able to apply it to our patients. And many of you may have seen some of this from SCCT 2023. These are my disclosures. What we hope to do and what I hope to share with you is first, is to recognize the high accuracy of CAD assessment through clearly guided cardiac computed tomography to improve outcomes in our patients. Second, how do we apply novel insights from Cleerly, as Jay had introduced to you, with validation to invasive standards that represent the gold standards for our field, like near-infrared spectroscopy or intravascular ultrasound, for high-risk atherosclerotic plaque to best identify patients at risk for ACS. And third is to understand the superior prognostic value of Cleerly quantitative plaque assessment when compared to current methods. And so, we have really expert readers here in this audience, but there also may be early learners or trainees that are part of this audience. And so we'll start with a case. This is a 61-year-old patient presenting with chest pain, and what we see on the left are these curved multiplanar reformats of the left anterior descending artery. And if you take a moment to look at it, let me just ask you to ask to yourself, what is the degree of stenosis that's present in this patient? So as you look at this, you'll observe that there's plaque that's present in the proximal LAD, the presence of both calcified and non-calcified plaque. And particularly if you haven't looked at many of these, you may see that calcified plaque and think that this is a severe stenosis, maybe over 70%, with non-calcified plaque present. And indeed, that was what the clinical site read was for this case, greater than 70% stenosis, a CAD-RADS category 4. And so what the software allows us to do is, after doing a clinical site acquisition of the cardiac CT scan, the images are sent to a cloud-based server through a secure connection to the web. And using AI and machine learning and a series of convolutional neural networks, there's automated segmentation of the images. There's automated selection to see what is the best phase of the images, and then whole heart segmentation, stenosis, and atherosclerotic assessment of the coronaries. And so what we're seeing from the AI software on the left is the same curved multiplanar reformat, now zoomed in on the area of lesion and segmentation of the left main, proximal, mid, and distal LAD. In the middle, if you look here, we can see a fly-through with contouring of the lumen and the plaque components. On the left now on the screen is a straight reformat. And oftentimes as readers, we may have a difficulty in seeing and characterizing the plaque that's present and the extent of the plaque, especially the non-calcified plaque. And so what the software is telling us is that this yellow is the area of non-calcified plaque, positive remodeling, and in the blue, as it had popped up previously, the area of calcified plaque. We can use this to generate an output, and this screen is the centerpiece feature of the AI and of the Cleerly coronary tool, giving us the plaque volume and the segmentation. We can get individual plaque and stenosis components for each segment, and then we can adjudicate using the software the individual lesion, see what the stenosis is, 53%, the luminal diameter, the lesion length, as well as looking at the plaque quantification across that coronary tree. And so if we summarize this case, this was a 61-year-old patient presenting with chest pain. The clinical site read was that this was severe stenosis on a CAD-RADS4 categorization. But if we apply AI to this and we apply the Cleerly coronary, the Cleerly read is of a 53% stenosis. And beyond that, if we look at, what is the actual ground truth? The QCA, the invasive quantitative coronary angiography, also confirms that this was not a severe stenosis, but more of a mild to moderate grade stenosis at 41%. And on this screen, we have a summarization of the really tremendous amount of information we're gleaning from the Cleerly coronary. The plaque characterization here with red arrows, the presence of non-calcified and calcified plaque, as well as importantly, something that we're not able to do on a clinical qualitative basis is what is the quantified amount of plaque that's present. And in this case, the total plaque of 291 millimeters cubed, and using a novel, recently validated staging system, stage 2 degree of atherosclerosis, in addition to this 50% stenosis or 53% stenosis that was present. To look at a further standard beyond QCA, the invasive FFR for this was 0.82, and further lining up this degree of stenosis as non-obstructive. And so now, how do we put this in context of the literature, and what is the value that Cleerly coronary provides for us? Well, we know that less experienced readers will overclassify obstructive CAD versus expert readers. And by overclassifying disease, it leads to excess downstream testing and excess costs for our healthcare system. This is data from the PROMISE trial. And if you recall from the PROMISE trial, when it was initiated about 15 years ago, many of the sites that were included as part of the trial were level 2 sites that were early in the experience of coronary CT as the field was in an early experience. Well, when the investigators went back and looked, core laboratory investigation classified 40% fewer patients as having significant or obstructive CAD compared with site interpretation, and PROMISE was a predominantly North American-based trial. 42% of the CT reads were done by less experienced level 2 readers. And we've learned from this and many other subsequent studies that more experienced readers are more accurate than less experienced readers. And so how can we build in improved reliability and accuracy using Cleerly coronary? One way that Cleerly does this is by using a novel definition for diameter stenosis. And so on the top of this slide is how I think many people and many of us in the field have been taught to learn not only in CT, but in the cath lab, how to calculate stenosis by taking the diameter of a reference segment and comparing it to the diameter of the luminal narrowing and using that to calculate the percent stenosis. I think many of our, maybe not people on the call, but in the cath lab or in CT may just do this as a qualitative read, or many times it may just feel like you're throwing darts at a dartboard to calculate the percent stenosis. What Cleerly does is to not only take into account the proximal vessel segment, the luminal stenosis, it also accounts for the distal stenosis, as well as interpolating for the lesion length from the reference to the area of most significant stenosis, because we know that this luminal narrowing doesn't happen in isolation. And by interpolating this, we can account for a more accurate and create a more accurate read. Now, how does Cleerly, or as being described in the medical literature, AI-QCT compare to invasive angiography, and how does it work as a gatekeeper to prevent excess invasive testing? This is clearly applied to the CONSERVE trial, an international multi-center study of 22 sites in which 100% of patients were referred for CAF, but randomized to CTA first. It was predominantly stable patients, an average age of 60, a very diverse cohort of about 50% women. And what the study found was that use of Cleerly coronary or AI-QCT may allow for an 87 to 95% reduction in invasive coronary angiography for stable patients with suspected CAD, and that there was no added risk of one-year major adverse cardiovascular events associated with a Cleerly or AI-QCT referral strategy. How does Cleerly compare against stress perfusion with QCA and FFR as a ground truth? And this is an important question because 90 to 95% of the sites in the United States are still using stress perfusion, particularly nuclear SPECT imaging as the means of detecting coronary disease. And so using multi-center data again and comparing it against very established standards of obstructive stenosis, 50% stenosis, 70% stenosis, as well as against invasive FFR of less than 0.8, which is the standard in the literature and for the field for significant coronary disease, Cleerly performed excellent with an AUC of about 0.9 across these standards. On the right of this slide is a case example of a patient that was deemed to have ischemia, as we see on the SPECT imaging in the anteroapical segment. But when we look on this, the AI interpreted, the Cleerly interpreted CT, 41% stenosis, non-significant and non-obstructive as confirmed on FFR, as seen on the bottom left of this image. How does Cleerly compare against invasive QCA? Again, in multi-center study against blinded Corelab QCA invasive FFR and against a 50 and 70% stenosis standard, we see that there's high accuracy against these standards, and the AUC was 0.9 with similar accuracy to QCA against invasive FFR. And so we asked ourselves, why is it that there's some discrepancy even between Cleerly and between QCA? And we found that there was about 10% atheroma volume present in these in these Cleerly coronary or AI-QCT cases. And if you look at the accompanying editorial written by Dr. Ed Nickel, the current president of the SCCT, he really asks ourselves, why is it that QCA is the standard when we know that invasive angiography may not pick up on non-obstructive plaque or plaque atheroma volume, for which cardiac CT is best suited and has best been shown to have accuracy and ability when we look at all of our approaches to CAD assessment. How does Cleerly compare against FFR-CT? Looking at the derivation of credence, we find that Cleerly is more accurate and more significantly accurate when you compare it to FFR-CT. And this is a clinical case example of a non-ischemic lesion by AI-QCT and invasive FFR that had been incorrectly classified as ischemic by FFR-CT. And this was the Young Investigator Award for Best Abstract presented by Rebecca Jonas last year with a publication near complete. And so that first case really shows us the high diagnostic accuracy of Cleerly for percent diameter stenosis as well as detection of plaque. Let me shift gears from a 61-year-old patient and now show you a case of an unfortunate case of a 37-year-old patient, somebody younger than me, and I know I look young. So 37-year-old patient presenting with chest pain. And so when we, after the site acquisition, it's sent again to the secure cloud-based server through Cleerly, goes through a series of convolutional neural networks, automatic segmentation with QA on the back end. What you can start to appreciate, and I know this video is going through quickly, is the presence of non-calcified plaque. And it often may be even challenging for clinical readers to see this. Now, based on our CAD-RADS 2.0 that I had worked on, the segment involvement score here is maybe 1 or 2. But what clearly is really helping us to see is the burden of plaque that's present, the non-calcified plaque, as well as in red, the low density plaque that we know from multiple studies is the best predictor of high risk plaque and future myocardial infarction. We appreciate in the middle here the presence of positive remodeling, as well as the really high plaque burden. On the right, we get a quantitative output of the amount of plaque that's present, now shown in the centerpiece, 314 millimeters cubed, predominantly an all non-calcified plaque with significant stenosis in the proximal LAD, as shown very nicely and graphically. We can adjudicate using the straight MPR that lesion, and then we can really look at all of the plaque characterization. Now, on the back end of this software, especially for those that are doing research, we get outputs across the whole coronary tree so that we get the numbers and we can really start to think about this on a broader scale. And then finally, get a report that can be customized to what your needs are at your site on the stenosis, the plaque characterization, and the total plaque burden across the coronary tree, so that you can use this to educate yourselves, your referring physicians, as well as your patients. And so to summarize this really unfortunate and I think tragic case of a young person, a 37-year-old that had presented with chest pain, for which the kind of current clinical approach failed him because it didn't detect the disease earlier on, or at least we didn't have the opportunity to catch it until it was at this time, until he had the Cleerly analysis. The Cleerly read was for 53% stenosis at a CAD-RADS 3 level. Using the novel plaque staging system, this was categorized as plaque stage 3 based on the percent atheroma volume of 19%, with a total plaque volume of 314 millimeters cubed, predominantly in all non-calcified plaque, in addition to the presence of, importantly, low-density non-calcified plaque. Unfortunately, 1 month after the CT, he had presented with an anterior wall myocardial infarction. And so I think as we see on the bottom here, we see the plaque characterization with the color coding. And on the right, the full layout of the quantitation of the plaque in each of the coronary vessels. And on the bottom right, each of the coronary segments using an SCCT coronary model. And so I think that really has us asking the question of what can we do to prevent heart attacks and prevent the onset of coronary artery disease in a patient like this and in many of our patients. It's Dr. Cury's data from Miami Heart published in JACC Imaging last year, as well as the 20,000 SCAPIS trial from Sweden in circulation 2 years ago that has taught us that nearly half of asymptomatic patients will demonstrate plaque, and that 1 in 6 of patients, particularly younger patients, will have a calcium score of 0, and that a calcium score alone is not enough to be able to detect early onset coronary disease in these patients. The SCCT has really published a very beautifully done atherosclerosis expert consensus, showing us how we can better identify at-risk patients for ACS or major coronary disease events, from at-risk, minimal, moderate, and high risk, and using the presence of high-risk plaque features beyond stenosis, positive remodeling, low attenuation, napkin ring sign, and really non-calcified plaque to be able to detect coronary disease. And I think the most important aspects of this are the presence of positive remodeling, low attenuation, and non-calcified plaque. We've seen, and what Cleerly is helping to teach us, and what we've been seeing through multiple papers in the literature, is that plaque exhibits a spectrum of atherosclerotic risk. Alex Van Rosendaal's paper in JAMA a couple of years back showing that calcified plaque or what they cleverly term as 1K plaque with a density over 1,000 Hounsfield units, is low risk, it's stable. That calcified plaque is how plaque is shown to be stabilized after treatment with statin therapy. And that on the other end of the spectrum, what we're trying to do is identify the non-calcified plaque, the plaques that are at highest risk for downstream rupture and myocardial infarction, as shown here on the left of this slide. Now, I was part of CAD-RADS 2.0. Ricardo Cury on the call was the chair of this document, and I think many of you were part of this, and I think many of you have seen this document. CAD-RADS 2 was an important advance from CAD-RADS 1.0 by adding plaque descriptors. And the idea was, how can we create standardization to improve communication and understanding of plaque to referring physicians? And so I think it was a good first step, incorporating a qualitative amount of coronary plaque, mild, moderate, severe, extensive, quantitative calcium, coronary artery calcium, but with the limitation that calcium scoring is not telling us what the degree of non-calcified plaque is. Looking at a segment involvement score, counting up, is there a presence of plaque, yes or no, across each coronary segment, and then a visual estimate based on the number of vessels and the amount of plaque that's present. And so it's a good first step. And this is a multi-society SCCT, ACR, ACC, NASCI document reminding us to report on plaque. But, again, there are limitations. And so here's a case example of a patient that has both calcified, but also a really high degree of non-calcified plaque. And so calcium scoring doesn't measure total plaque burden. A visual estimate or SIS adds time to your day. When we introduced this to my radiology readers in the group, they said, well, SIS is great, but it means I need to take extra time to really go and adjudicate this. I don't have the time to do that. There's variability between readers when you look at visual estimate. It doesn't see non-calcified plaque. And if we think of our current manual approaches to quantification, which are not clinically really available, it's time consuming. And it's predominantly in the domain of research. And so what we have shown is that there is high variability amongst expert readers for plaque assessment, especially when you look at non-calcified plaque, which is tough to do. And this was in comparison to multiple level 3 readers from the Clarify multi-center clinical trial that was conducted here at GW. Clearly depicts now more high-risk plaque compared to level 3 readers. 58% more patients were seen and identified as having high-risk plaque than level 3 readers that you and I may be missing on a qualitative basis. And so this is a case example that the clinical readers missed this on the left, but on the right, if we zone in on the arrows, we can see the positive modeling, but also the low density plaque that may be hard to see if you're going through a very busy day of many, many scans. Now, what about against ground truth near-infrared spectroscopy and IVUS, which is the standard for the field? Clearly, accurately depicts high-risk plaques against this ground truth invasive standard with high accuracy, sensitivity, and specificity. Cleerly is also redefining what it means to have a high-risk plaque. And this is looking at patients that had stable chest pain that later developed a future acute coronary syndrome from the iconic trial and matched against controls. And what Cleerly is really teaching us is that maybe we can take this one step further and look at the plaque morphology and shape of the plaque, and that being a better predictor of who is going to eventually develop a heart attack so that we can better intensify treatment for those patients. And I think very importantly, how does this plaque staging or total plaque quantification help us predict long-term or 10-year risk? This is a paper published, led by Nick Nurmohamed, who was a research fellow in our group this past year, now back at the University of Amsterdam. And what Nick did is apply this to a cohort of patients that had 10-year follow-up and looked at major adverse cardiovascular events. and lined up what happened if we applied plaque staging, looking at plaque stage 0, 1, 2, and 3, and compared it against our standard methods for clinical risk assessment, against coronary calcium scoring, against manual plaque quantification, as well as against CAD-RADS 2.0 assessment of stenosis and plaque. And what Nick's study had shown, is published in JACC Imaging earlier this year, is that Cleerly, or AI-QCT, improved and was the best predictor of cardiovascular risk assessment at 10 years against all of these standards. And I think really helps give credence in how we might apply this in clinical practice. And so to summarize, clearly guided assessment of CAD has high diagnostic accuracy to enable improved outcomes. Clearly offers novel insights into high-risk atherosclerotic plaque that includes validation to NIRS and intravascular ultrasound that best identify patients at risk for ACS, and clearly demonstrates improved prognostication for cardiovascular events through quantitative plaque assessment when compared to current guideline-based methods. Thank you for your attention. I look forward to our discussion to follow.
Thank you very much, Dr. Choi. Really great talk, great overview covering the data, the scientific validation for AI quantification of coronary stenosis, quantification of coronary plaque, insights in vessel ischemia, and also the detection of high-risk plaque features. So really, really great overall overview. We appreciate your insights. With that, we are going to move to the next speaker, Dr. Subha Raman. Dr. Raman is the Vice President of the Heart and Vascular Institute of Ohio Health, and it's a pleasure to have Dr. Raman with us today.
Thank you so much. It's great to be here with this esteemed panel, and it's great to be connected to all of you who are in attendance. So I'll talk about current approaches to preventing myocardial infarction. I'll focus my segment here on individuals with diabetes and offer a novel approach based on what we can do today, which is detect and track the disease that causes MI. Show you how we implemented this in a population health program, and finally discuss some treatment considerations. So a few words about diabetes are warranted. As we all know, it's terribly common, both in the United States as well as around the world. And it can fuel atherosclerosis through the earliest stages, through the development of more complex plaque, and through a variety of mechanisms, both hyperglycemia, inflammation, and thrombosis that all interact to increase an individual's risk of disease. And atherosclerosis, of course, is the disease that forms the basis of the vast majority of myocardial infarction, stroke, and even heart failure and peripheral vascular events. While we've made progress, there's still excess risk, particularly in those with diabetes, and that risk varies by race and ethnicity. Younger individuals remain at risk. This was a study looking at rates of myocardial infarction in those with diabetes in their 30s, 40s, and early 50s, and you can see the rates remain significant. So can we do better? As Dr. Earls alluded to, can we diagnose and treat the disease, not just risk factors for disease? So how do we do it today? Well, if you look at the guidelines from ACC, AHA, et cetera, they say, let's use the pooled cohort equations, right? Calculate an individual's ASCVD risk, and then apply to everyone in a fairly uniform manner, lifestyle modification recommendations, blood pressure management, and so on. But we know atherosclerosis is actually not a homogeneous one-size-fits-all disease across patients, particularly with diabetes. And CT has illuminated this fact very nicely. This is data showing both coronary calcium burden that varies quite widely amongst participants undergoing coronary CTA, and percent stenosis varies as well. Leading the ACC and AHA in their 2023 heart disease and stroke statistics document to say diabetes is indeed associated with great heterogeneity in risk, and many individuals with diabetes would not be considered a coronary heart disease risk equivalent, emphasizing the importance of risk stratification at the individual level for those with diabetes. Now, this is a busy slide, but I'll draw your attention to the fact that treating atherosclerosis in 2023 offers so much more than statins. Within lipid-lowering medications, we have a number of agents that have shown efficacy in treating the disease and reducing heart events. We have both antithrombotic and antiplatelet therapies, anti-inflammatory medications, and particularly for those with diabetes, their anti-diabetic treatment itself has been shown to be very effective in preventing myocardial infarction, stroke, and cardiovascular death. So putting all of this together for the individual, we need some guidance on how to pick from this armamentarium of treatments. Atherosclerosis is, of course, very quantifiable with CTA and AI. This is a staging approach that we can take now using this analytic approach. And we can look just from a distance and say, this patient, for instance, with stage 2 disease, surely has different risk than this person with essentially no detectable atherosclerosis. As Andrew showed, we can now understand prognosis based on the staging of disease with AI and Cleerly analysis. So you can see the very stark separation of curves in terms of survival free of major adverse cardiovascular events, worsening by stage of disease by the classification that I showed you on the prior slide. So can we use this approach to stage and treat atherosclerosis? This was a question posed by the ACC's Innovation and Prevention Working Group. And the analogy would be, how do we address individuals' risk of colon cancer? We don't wait for symptoms. We don't wait for that tragic event to become manifest. We look for early signs of the disease with colonoscopy, and we manage that early disease based on the stage. We can now take the same approach with coronary atherosclerosis. And this was published in the American Journal of Medicine just in the past year. So let's look at these treatment algorithms in a little bit more detail. If you have completely clean coronaries, this is an opportunity for not only continuing goal-directed medical therapy, but perhaps there's an opportunity to de-escalate. And that's where thoughtful clinician engaging with the patient through shared decision-making can decide what's best for that person to take, what may not be effective or useful. One can make sure that strategy is effective, perhaps by rescanning this interval for someone with normal coronaries, given the prior data on warranty periods suggests 4 years. At that point, if you do have disease progression, we can modify the approach. Let's say there's stage 1 disease. There's clearly a burden of atherosclerosis that's become manifest. High-intensity statin should be considered, perhaps with ezetimibe. And that interval of rescanning may be shortened a bit, given the stage of the disease. And I won't go into detail in the next 2 slides, but you can imagine if you have a higher burden of disease, that armamentarium of treatments should be considered more broadly. And not only that, as you would be more concerned about earlier repeat colonoscopy in that patient with a very concerning lesion, our interval to rescan might be shortened as well. So now can we apply this to patients? So we did this in a pilot program across a multi-facility health system. And I'll start with an important term to guide this part of the conversation, which is population health, defined as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. Population health from a health system standpoint can be viewed as the population of individuals for whom we take financial risk. And this can occur through employer health plans, things like Medicare Advantage or other value-based contracts, which are forming an increasing proportion of the covered lives managed at any health system in the United States particularly. We implemented this pilot program offering CTA and Cleerly analysis to those covered lives in the population health universe with diabetes, offering detection and measurement of coronary disease, anticipating we could offer better health outcomes. If we diagnose and treat the disease, we can prevent the events that we know that ensue. And can we do this in a financially responsible way? From a health plan perspective, if I'm spending something up front to treat disease and saving money downstream from a very expensive MI or stroke event, does that help the financial health of our health plans? So the workflow was a bit complex, but let me try and walk you through some of the highlights. Eligible health plan members receive an invitation letter, and it's upon them to contact customer service to take advantage of this health plan benefit. Once they're in, then 2 orders are teed up. One is the CCTA with Cleerly analysis and any needed pre-medications. Then the scan is completed with the analysis and the reports go to the electronic health record. The participants really enjoyed having access to the lay language report, and they were encouraged to review this before going over the results with a clinician. They were offered a visit with a cardiologist or nurse practitioner, going over that report and developing a treatment plan for any disease that was identified. They also maintained care with their primary care physician, and the program is coordinating follow-up through the health plan. So far, uptake has been about 1 in 5 eligible individuals, which actually compares very favorable to other screening or preventive type offerings through the health plans. This lay language report is something worth looking at and more closely. Around 4 sections, and I tell patients when I meet with them, the first 3 are going to be more general information, again, written at a 5th grade reading level, so very accessible to just about everyone you're going to see. And then once we go through that, they're ready to understand, what did the scan show in my coronaries? So let's look at a participant. This was a 63-year-old female with diabetes. No exertional symptoms, but relatively sedentary. She worked as an administrative assistant. She'd had diabetes for a number of years, as well as hypertension and hyperlipidemia. And for her, the main motivator to participate was her family history. Her mother, who also had diabetes, died suddenly at age 59. You can see she was on a reasonable medical regimen, good diabetes, blood pressure control, and we said, well, let's look for the disease. Quite remarkable if you look at the burden of disease in all the coronaries. And you can see this percent atheroma volume, very, very high, puts her at stage 3 per that staging method that I showed you earlier. We talked about options through shared decision-making and decided on adding ezetimibe. And she had some room for lifestyle improvement as well. And so she said, you know, I can take advantage of the nutrition counseling that's offered through the health plan and engage in more physical activity. She came back about a year later with slightly better blood pressure. Her weight had come down. A1C was about the same. And her plaque was relatively stable. And the ability to look at the disease in such a quantitative fashion really made an impact in this encounter. So she still has significant disease, but is very attuned to what she needs to do to keep it stable. Our ROI analyses are ongoing. We're looking at things like our health plan expenditure on drug therapy, our total healthcare expenditures, and of course, health outcomes such as atherosclerotic events, but also measures of cardiometabolic health. What I've learned from this, and I look forward to our discussion, is that motivated patients really do want access to technologies that enable more informed prevention of disease. Population health can be a useful platform to deploy these novel approaches to diagnose and treat disease, not just risk factors. And as you think about your interest in this program, try to align with your institution's goals. If you're operating in a fee-for-service environment, think about the downstream care that can ensue. If you're in a value-based care environment, think about how you will demonstrate cost effectiveness. Thank you for your attention.
Thank you very much, Dr. Raman. Really insightful talk, like really linking population health and how to deploy clinical pathways and also AI technology to move from population health to really precision medicine. And we have a couple of questions in the Q&A, but like just to kick it off, and I will start with Dr. Raman. How could you provide more insights? So, there is all guidelines in, caring for a population, like in your position as a vice president of a large heart and vascular institute. How do you monitor and how you go from this population health to more precision medicine in caring for individual patients? So tell more about this journey.
On behalf of the team, Dr. Cury, you've got a little bit of an echo, so I've been asked to pass that along. If I understood your question correctly, how do you translate kind of population scale insights, even from guidelines, to deliver more precision care for individual patients? And I hope that the answer to that is what we've seen. At the individual patient level, we know that person's burden of disease. We know that person's characteristics of disease burden. And so we can take all the guidelines, we can take all the evidence, that treat to disease algorithm that came out in American Journal of Medicine, and talk to patients. Here are your options. Here's what your copay might be if we add this medication, and talk about what makes sense at the individual level. And that's I think, a very powerful way to take tremendous evidence and deliver it in a way that impacts that individual's life.
Very good, very good. Great thoughts and considerations. For Dr. Choi, a couple of questions. If you could share your pre-beta blockade protocol to optimize coronary CT angio and to optimize the AI analysis and any insights into reimbursement. Try to tackle two questions at once.
Yeah, so the first question, Ricardo, was about beta blockade. And so I think the first underlying point to make is that Cleerly software works across hardware platforms. And so whatever your scanning vendor is, the application of the software, and there's published data on this as well. And so the accuracy should be consistent across those vendors. Next, I would just point to current SCCT guidelines that you may consider anywhere from 25 to 150 milligrams of oral metoprolol an hour before the scan. Consider 5 to 25 milligrams of IV metoprolol on the scan. Even an outpatient setting, you might consider giving beta blocker the day before or asking your referring physicians to provide the beta blocker the day before. And then beyond that, it will also depend on the scanning platform that you have. And so the very newest generation scanners may have a little bit better allowance for higher heart rates compared to being on a 64-row scanner, which may need very, very tight heart rate control for the best scan accuracy. I think the second question, maybe I will defer that to Dr. Earls on the current reimbursement status.
Sure, I'm happy to handle that. Thank you, Andrew and Ricardo. For reimbursement, we are still early in our reimbursement journey. Fortunately, in 2 of the 7 MAC territories in the U.S., for Medicare coverage, they are paying currently for the plaque product. I think that's in about 12 states, mostly centered in Texas and southern states, but also some East Coast states. So I would check with your local MAC or reach out to us and we can discuss that. From commercial payment, generally that lags behind a broader Medicare coverage. And we know that the remainder of the Medicare provider networks are currently working on a coverage document at this time. We don't know what that will be, but we do hope early next year fingers crossed, we should have much broader coverage, assuming those coverage documents are favorable. From a provider standpoint or commercial coverage standpoint, we do have some coverage through them, but again, it probably is lagging behind that of Medicare. We also, however, have programs where for symptomatic patients, if the CT is covered, we often will join into a shared risk program with providers or with institutions. If the Cleerly exam is covered by insurance, then we will split that revenue with the site. But if this study is not covered or rejected by insurance, then we do not require payment. What we get there is actually we ask for the insurance data, so it's an exchange in kind because we do need claims going to the commercial provider so that they in fact know that people are doing this technique, and so that is something of value to us. So again, we're happy to discuss the details of those with folks. We do feel like we're making good progress overall with some Medicare coverage now, and hopefully 6 or 12 months from now we'll be significantly further down the pathway.
Let me add to that, just as a regular site, is that there is a new CPT code centered around plaque quantification. And I think that's part of what Dr. Earls, what Jay is alluding to. And I think importantly, I think there's not a one size fits all when it comes to how you approach reimbursement and this side of it. And I think what Cleerly has done extremely well is to be able to work with an individual site to see what makes most sense.
Fantastic, great insights. Maybe one last question for the panel. Any insights into ischemia? I think a lot of work being done for AI quantification for stenosis, for plaque, which is terrific. What about the evolution into defining ischemia in these specific lesions?
I can take that one, Ricardo. As many people know, we do actually have an ischemia algorithm that was recently approved by the FDA, which we will be launching commercially early next year. We're very excited about it, and we've had some good validation results in several multi-center clinical trials. So much more on that in the near future, but something that we're excited to then offer a comprehensive suite of stenosis, plaque, and then ischemia evaluation of coronary CT. We're very excited about the possibility of that here in the near future.
Fantastic. I think we are about time. So I really would like to congratulate all the speakers, Dr. Raman, Dr. Choi, Dr. Earls. Great overview. All the participants, thanks for being with us. And enjoy the rest of your day.
Thank you,
Thanks,
everybody.
Jay. Thanks, Ricardo. Bye.
Thank you.